Hello, I'm Martin Leon, and we're sitting at EuroPCR. It's a beautiful spring day in Paris. I work at Columbia University in New York City, and it's my pleasure to welcome you to this editorial discussion entitled Beyond TAVI. I'm very fortunate to be joined by Alain Cribier from Hospital Charles Nicolle in Rouen, France. Seated next to him is Pieter Kappetein from Erasmus Medical Center in Rotterdam, the Netherlands. And then, of course, Stephan Windecker from Bern University Hospital in Switzerland. This should be a very provocative discussion among colleagues representing both the interventional and surgical communities on where we go from the basic point of TAVI as we are today. And my first question is, we have just completed a randomized trial in the United States which took 5 years between planning and enrollment and analysis. And I'm particularly interested to get a European reaction to the results from the partner trial. Is there anything in particular that struck you as being especially noteworthy that we can learn from? Peter, do you have any thoughts?
Yes, I think what the partner study has shown us that there were actually very good results, both on the TAVI arm and the surgical arm. If we compared it to registries in Europe, and also the surgical cohort, if we compare it to surgical results in general, I think the partner A cohort showed great results in both arms. The TAVI arm was a little bit better. The outcome, the 30-day mortality was lower than in surgery, but I think that has to do much with the comorbidities that the patients had. But you see that there's an early rise in mortality in the surgical arm, and maybe that is due to the comorbidities that the patients had. They had a high SCS score of around 11, 12. Euro score was high, so I think that played a major role in the surgical outcome.
Alain, were you surprised at how well we did with the early results with TAVR in the United States?
Well, actually, I was very surprised. I was a little disappointed that the American did better, and so I was really wondering why was it coming from. And because I had the feeling that we have a lot of experience, and so, but the mortality rate in the partner trial in the United States was particularly low, and I guess that it might be related to the careful selection of patients. I think in this partner trial you had a very strict protocol for selecting the patients, and imaging was absolutely well done. And in Europe, I must say that in many teams, the selection of patients is a little less good. And especially the imaging technology used for selecting the patients are not complete. So I have to fight myself, when I am proctoring cases to get a CT scan, for example, for the femoral approach, and this is something which is not done everywhere. So this might explain some increased vascular complications and subsequently a higher mortality rate. Yeah. I think this is coming from this part of selecting the patient.
Mm-hmm. Stephan, the complications in the TAVR arm, were there any? I know many people have talked about the strokes and other things. Were there anything that was interesting to you as you looked at the data?
Well, I think complications are certainly still an important consideration, and I think what we have learned from both partner B and partner A, that there are probably two important sets of complications which affect the long-term outcome and survival. And I think one important one is stroke, and the other are major vascular exercise complications. Now, I must say, I think in the interpretation of the overall results of partner A, I am not too surprised about the stroke rate in this very elderly population. If you look at the high-risk profile, they are octogenarians. They have a high incidence of pre-existent cerebrovascular disease. They have an incidence of more than 40% of atrial fibrillation. Then I think the overall rate of stroke of 5% in the TAVI group are actually absolutely acceptable and what I would have accepted. On the other hand, I must say I was very surprised about the very low rate of stroke in the surgical arm. And certainly there I would be curious to have the perspective of the surgeon. Is that what you usually see in such a high-risk population, or is that actually a chance phenomenon? Because all in all, I think we need to say partner was a trial to assess mortality, but it was not a trial to assess a stroke.
Well, I think that the stroke rate is what you can expect in the surgical population. It might be a little bit on the low side, especially because these patients were so old and had so many comorbidities. But I think it's not higher or lower than what we normally see. So I think that, but even in the TAVI cohort, it may improve in the coming years when you have smaller devices and new techniques to implant the valve. So it was a little bit striking, the stroke rates in the TAVI arm, but I think that might improve in the coming years.
You know, we employed this aggressive, and we learned from our European colleagues, this heart valve team approach. In fact, surgeon was required to be in the room on every case. There was never a case done in the partner trial where there wasn't at least one surgeon and interventionalist. And we feel that made a difference because we feel the surgeons know a lot about valvular heart disease, and there was a lot of positive insight that was provided by our surgical colleagues. As these therapies become more generally used, and now you see it in Europe, so commonly used, can you maintain this heart valve team approach in general clinical practice?
Well, I can answer this question because this is something that we can observe more and more in Europe, that the notion of heart team is absolutely there for the selection of patients. So the heart team is mainly used for selecting the patients, and we need the advice of the surgeons and the anesthesiologists and the radiologists and so on, echocardiographers. Well, actually, the heart team in the cath lab is something different. I mean, more and more, I can observe that the surgeons are not in the room because, especially since we have been improving the devices, decreasing the size, today this technology is done like a stent-like procedure. Everything is done percutaneously in more and more centers using ProStar to close the femoral artery. So actually, the surgeons may be around, but they are not really in the room. So this makes a difference probably with what is going on in the United States. Yeah.
Doesn't mean that perhaps in the United States in 1, 2, 3 years' time it may also change, or what is your... Yeah.
I think it also depends on the type of procedure. I completely agree with Alain. Obviously, for the transfemoral route, it's exactly the case that actually surgeons are less and less involved, or you have a now new kind of surgeon who are actually more and more interested in more interventional procedures rather than traditional surgical procedures. Conversely, I think for the transapical procedures, I think there is a sense of the heart team even in the operating room, where the surgeon does the procedure in surgical terms and the cardiologist assists with placement of the valve and sometimes also adjunct percutaneous coronary intervention if required.
Yeah. Yes. I think that if the surgeons want to stay involved, we have to change our training program. I mean, then surgeons have to learn how to use catheter-based techniques, and otherwise, you will see what you're observing, that less and less surgeons are involved with the cases. So
Peter, we are doing that right now, and it's something that we feel strongly about. And we have a surgical interventional training program, and at least every year we have at least one fellow who really dedicates themselves to spend a full year doing interventional procedures, 4 days a week, taking MI call, doing STEMIs, and it's been very revealing. I've been surprised and a little bit intimidated how quickly the surgeons can pick up catheter-based techniques if they focus and dedicate themselves. So I think that will be a trend in surgical training, and it's a trend that I would strongly endorse.
Well, certainly faster than us picking up surgical skills.
Maybe.
Now, we touched on some of the complications, and I guess one of the questions is, we observed that between the two cohorts, and although the trial was conducted in parallel, we finished one earlier than the other, and all of the centers did not participate in both of the cohorts. So there was a learning experience, and frankly, the complication rates went down somewhat between the two cohorts. And I think it was more than just the differences in the patients. But the question is, how much further can we improve the procedure, reduce complications and high risk, and what would be the areas that we should focus on? Any thoughts?
Well, actually, I can just share with you my experience in Europe, but we are entering a new era with this technique, since we have been so much improving the devices. And reducing the size of the introducer, for example, is a major event. And also the valve itself is much better. The experience is here. So I am thinking, with a good learning curve, crossing the aortic valve, for example, which is something that everybody does, can take between a few seconds to 5 minutes, or even more. And so the experience in crossing the aortic valve reduces the time when you are playing with the valve, and maybe this could reduce the risk of stroke, because the strokes are mainly associated with manipulation of devices in the area of the valve, inside the valve, and so on. Trying to shorten each step of the procedure is in this regard probably very important as far as the stroke rate is concerned. So I think that the advance in technology will be associated with a strong reduction in overall complications.
Mm-hmm. Do you think imaging may help there?
Yes, absolutely. Imaging is fundamental, and we know today how to select the patient for a transfemoral approach much better than before. And I can remember the early time when we put on the table patients who had the clear late tortuosity calcifications on the iliofemoral axis, and today this is something that is totally avoided. And we have alternative techniques such as the transapical, but we have also a transaortic approach today available, so this makes the whole thing quite different.
So the three new areas people talk about are cerebral protection, other ways to perhaps reduce strokes, dedicated devices for closing the vessel, and improved imaging techniques. Any thoughts, Stephan, about which of those you think in 5 years from now will be part of the routine of how we do TAVI?
I think it's very difficult to predict, but I think in a certain sense they are complementary. Alain alluded to the fact that downsizing of the vascular access site is an important feature to reduce the access site complications. I think along with this we will also probably see a reduction in the event rates in terms of stroke, because probably these devices with a lower profile are less harmful to mobilization of any plaques on the aortic arch. I think another important consideration in my view will be that we learn more about the appropriate adjunct medical therapy. I think here we also can capitalize on our experience with percutaneous coronary intervention. It all started with aspirin and Coumadin in the early days, and then was much facilitated with dual antiplatelet therapy as we know it today. And I think here we know very little in terms of what are actually platelet activation, thrombin activation in response to the procedure, in response to the bioprosthesis we are implanting. So I think we will see complementary techniques of imaging, of devices in pharmacotherapy, very similar to what we have seen in percutaneous coronary intervention, but which single technique then will result in lower event rate, I think it's too premature to say.
Stephan, I think that's very insightful, because we've already revised the pharmacotherapy regimen in Partner 2, thinking that we were a little bit too lax, not as disciplined in terms of recommending a strict regimen. And we observed at certain centers more of a clustering of events, and there may have been some systematic differences in both the procedure and the pharmacology that could have accounted for that. So that's an area that we have not focused upon, but I agree that's an interesting area to pursue in the future.
I can actually add that in the surgical mechanical valves it was about the same. They started with aspirin and Coumadin without any evidence that was the right therapy. And I think we also have to find the right anticoagulant regimen for percutaneous heart valves.
I do worry a little bit, because at least these patients, they're elderly, they're frail, they have multiple comorbidities. As we get more disciplined, it usually means more rigorous. With the dual antiplatelets or with antithrombins, we're now going to be using dabigatran in more patients. I worry about the bleeding risk in some of these patients. So we're going to have to learn this over time. It's hard to predict how that will sort out.
Yeah.
But in itself, it's a high-risk population, and if you just look, let's say they wouldn't have aortic valve disease, they just would present to you with their age, left ventricular hypertrophy, and atrial fibrillation. You would be bound to perform oral anticoagulation. So it's always this difficult patient population where you're worried about bleeding due to your therapeutic intervention, but nevertheless, at least the guidelines and the evidence tells you to do so.
Well, if you just look at the cohort B, the inoperable patients who didn't get TAVI, they had a stroke rate of almost 3%, major strokes of almost 3% between 30 days and a year. So it's a very stroke-prone population.
Yeah.
And I must say a very important message, at least to me, from the partner B cohort, which I consider equally important to the cohort A, is that actually the peri-procedural risk of the intervention itself did not exceed the spontaneous course of disease. That is, although we did an intervention with large bore catheters, the spontaneous course of disease in terms of mortality was at least, if not more, malignant in the early peri-procedural period.
Mm-hmm. Yeah.
Well, I heard a shocking statistic to me yesterday at EuroPCR. The shocking statistic was that if you look at 2011, this year so far, of all the patients who are getting surgical aortic valves, among those that are getting biologic valves, that half of the patients are getting TAVR as opposed to surgical AVR. So 50% in Europe penetration of TAVI in patients who would otherwise be receiving a biologic valve. That's a very high number, and I was shocked to hear that. Excited, but shocked.
Excited.
Excited, but shocked. So it begs the question, where do we go next in terms of clinical indications, and what data do we need to justify such broad use of TAVI in the future?
Well, I think it's a little bit expanding the market. So that was at the beginning. We saw also a growth in surgical valve replacements. Now we see, I think, a little bit of a decrease. And I noticed that during our heart team meetings, that sometimes a patient is discussed that 5 years ago we would say, of course, that patient gets a surgical valve replacement. But now that we have such good result with TAVI, we say, well, TAVI in this patient might be a much better option. A good example is that with a patient with coronary bypass surgery in history, you know, in the past we would say, okay, we can operate, we can replace the valve. But nowadays, now that you have the option of a TAVI procedure, you say, okay, let's go to TAVI. And therefore, it will decrease the surgical volume. And
actually, I think this raises the important question of extension of indications. You know, so this is in the air in Europe, and I can observe it frequently that less and less patients are refusing TAVI just because the score is low. So we have a trend to lower the Euroscore in Europe and to include more and more patients who would be normally relatively good surgical candidates. So we have a lot of discussion in Europe on that. And I think that it's difficult for us to maintain the indications under control. And this is clearly observed in the south of Europe, in Middle East, for example, in some Eastern countries. This may escape, you know, to the strict recommendation. So lowering the Euroscore, including patients at low risk for surgery in TAVI, is something in the air, and we have to keep an eye on that.
yeah.
I think that's certainly important that we keep an eye on the indication, but on the other hand, I think one advantage of the natural competition between the transcatheter technique and the surgical technique is that now more patients have access to the treatment, because I think it's clearly evident that there has been under-treatment so far. So I think that is something which has been ignored for quite a time, that a considerable portion of patients who fulfilled indications actually did not have access to any kind of therapy. And therefore I think that's a major advance in medicine, that we can provide therapy to a larger patient population. But the other obligation obviously is now to establish evidence in lower risk, intermediate risk patients.
Yeah. Because these patients will probably live longer and need, so their valve durability needs to be longer than in the patient population that we treated before with TAVI. So I think it is important to get the evidence.
Well, they'll live longer, but also the surgical mortality in some of these lower risk patients is going to be much lower. I don't know if we could tolerate stroke rates of between 3 and 5% if they're the same in younger, lower risk patients. We assume they won't be. So I would encourage people to collect data very carefully, because we don't want to have, this is a marvelous new procedure that Alain has introduced to us. We don't want to have it tainted by it being exposed to too many patients too soon. I think it can mature in a very disciplined way over time, but I think it's always better when the evidence drives the use as opposed to the use getting ahead of the evidence, and then we have to start reconsidering where we go next.
Actually, I would be curious, Marty, to have your opinion about the way to proceed, just to assess whether the results of TAVI and the stroke rate, for example, would be lower in low-risk patients, because we don't have low-risk patients in our series. So how to proceed? Do you think that we should do some kind of randomized study between in intermediate patients, or to move progressively with a lowering Euroscore? How to proceed? This is very difficult.
Well, it's interesting because we brought the data from the partner trial. We were very enthusiastic to the FDA, and we presented to them an all-comers trial to really bring to the intermediate and even lower risk patients. And the FDA said, we're not ready for such a trial. So they said, let's go to the intermediate risk. So we do have a category now of intermediate risk, and I know TAVI in Europe and Partner 2 in the US will be just looking at these intermediate risk patients. And these will be randomized trials of over 1,000 patients. And I think, even though not powered to show low event rates like stroke so well, we'll get a good indication of whether or not the stroke risk is going to be less in these patients. And now the age will go down substantially to, I'm sure, it was 80 to 85. Now we're going to be more 70 to 75. So it will be interesting to see how the results differ.
Yeah, absolutely. And I think that with the TAVI trial also is that you don't have an age limit anymore. So it's just a score, the SCS score between 4 and 8, that will be the inclusion criteria for the patients. So therefore we will lower it. It was 12 in the Partner A and Partner B cohort. So we will go to an intermediate risk patient population. And we need the evidence there.
So in conclusion, I've got one final question for Alain. Could you ever have imagined 10 years ago where we are today with TAVI?
Well, actually, 15 years ago or 10 years ago, no, I could not imagine that this technique would spread so much worldwide, and also that it would be so well accepted by both the communities of cardiologists and cardiac surgeons. I think an important aspect has been that the surgeons have felt also concerned by the technique. So we were not opposed to surgery. They were participating. They were part of the heart team. And this made the difference and allow us today to understand why this technique is spreading so much. Mm-hmm. I would just conclude on just one word, that we have been talking about considering what could we do to decrease the complication rate. I think there is another aspect today, is to know when to say no to TAVI, even to TAVI. So this is something that I can to bring in the training programs, because until a recent period, all the patients who are not surgical candidates were sent to the interventional cardiologist for TAVI. Today we know that some indications are not good. And we have to learn how to discriminate patients who are relatively good candidates for TAVI and not good candidates for TAVI. And we must learn how to say, no, you are not a candidate.
So might it be a good idea also to have a very good screening log for the new Partner 2 trial and the TAVI trial? Yes. I mean, that is, I think, is essential to learn that, especially that aspect. So who were screened and who were refused for either surgery treatment or TAVI treatment? How many patients were screened for Partner?
A total of 3,105. So actually 34% of the patients were ultimately randomized into either one of two cohorts. Among that pool of patients who were said to have a high risk features, symptomatic and severe aortic stenosis. So the screen failure rate was about 2 out of 3.
Right. And we don't know what the result was in the patient that did not get any treatment.
No, that's a very good point. And we hope to be able to do that differently in Partner 2. Right. Well, this has been fascinating. I always learn when I'm exposed to my European colleagues. You have such a breadth of understanding and a lot of practical clinical experience. So on behalf of Alain Cribier, Pieter Kappetein, and Stephan Windecker, I want to thank you all for joining us for this session on Beyond TAVI.